Good afternoon, everyone. My name is Harper Schwartz, and I'm an analyst on the Maternal and Child Health team here at the Association of State and Territorial Health Officials, or ASTHO.
And my name is Ramya Dronam-Raju, and I'm an analyst on the Chronic Disease team at ASTHO. We would like to welcome you to today's ASTHOConnects webinar on tobacco exposure and the impacts of early brain development. Today, we will explore how states and territories are preventing tobacco exposure during pregnancy and opportunities for state health department staff to work in the area of tobacco cessation and early brain development. We will discuss the science behind prenatal and early tobacco exposure and the impact on early brain development, and we will learn about the implementation of successful tobacco cessation and smoking reduction programs within the maternal and child health population. Today we will be hearing from Andrew Jaffe from the Lieber Institute for Brain Development, Glenn Zarnecki from the Southeast region of the Tennessee Department of Health, Lisa Dixon-Gray from the Center for Prevention and Health Promotion, Maternal and Child Health Section, and Amber Miller from the Yamhill County Public Health Department.
Tobacco exposure during pregnancy is an ongoing problem in the United States that can lead to detrimental effects on the fetus and early brain development. ASTHO works closely with federal agencies and state health departments to support initiatives addressing early brain development and tobacco cessation programs through state and systems-level policy change. Before we hear from our first speaker today, I would like to turn it over to Cherise Walkoff, Public Health Advisor in the Office for State, Tribal, Local, and Territorial Support, for brief remarks on behalf of the CDC. Cherise, feel free to take it away when you are ready. Hi, Cherise. If you are on, we cannot hear you. You might be muted if you want to try again. And thank you all for bearing with us while we deal with these technical difficulties.
Can you hear me now?
We can. Go ahead.
Oh, great. Okay. I'll start over. Sorry. So I was saying that I'm really glad to be joining you all on this webinar today. I greatly appreciate the opportunity to work with our ASTHO partners on this important project. CDC's Early Brain Initiative is inclusive of work that influences brain structure and function over the course of the lifespan, from before conception through early childhood. Much of this work is focused on promoting and protecting brain health, promoting in the areas of early intervention for medical and biological issues, positive parenting and caregiving, and nutrition and activity, preventing in areas such as hazardous exposures, adverse childhood experiences, infections, and injuries, and all of this, all accounting for and addressing social determinants and contexts of health. By conducting robust science and service and surveillance, we anticipate achieving outcomes such as enhanced learning, socio-emotional, language, and cognitive skills, healthy stress response, not hyper-responsive or chronically activated, longer-term outcomes such as just healthy development, overall development, and impacts such as better health and positive intergenerational effects. So, better understanding the science behind prenatal and early tobacco exposures, as well as evidence-based best and promising practices on the implementation of successful tobacco cessation and smoking reduction programs that we will hear about today, are vital to achieving these outcomes and providing evidence needed to help inform and shape the policy and guidance on early child development. I am looking forward to learning so much from our speakers today. Thank you.
Great. Thank you so much, Cherise. I would now like to introduce our first presenter, Dr. Jaffe. He is the lead investigator for the Lieber Institute for Brain Development and an assistant professor at Johns Hopkins Bloomberg School of Public Health. You can find his full bio in the chat box. We will wait to answer questions until the very end of the presentation, but we do welcome you to chat your questions into the chat box throughout. Dr. Jaffe, go ahead and take it away.
Hi, this is Andrew Jaffe here. Thanks a lot for inviting me to speak today. I think I should have control of the screen now. Is that how this works? Yep. Okay. Cool. And so Today, I'm going to be talking about some of our recent work to look for the effects of nicotine and maternal smoking during pregnancy on the developing human brain. Let's see. And so this work was recently published in the journal Molecular Psychiatry over the summer, and it was led by a post-bac fellow, Steve Semick, who's now a first-year medical student at the University of Maryland. It was also in collaboration with Joel Kleinman here at the Lieber Institute and Dana Hancock at RTI in North Carolina. And so just to give you guys a little background about us, we at the Lieber Institute for Brain Development are a nonprofit research institute affiliated with Johns Hopkins University. We were founded by philanthropic money to better understand the molecular correlates of serious brain disorders like schizophrenia. And three main areas of our research involves looking for how genes contribute to risk for brain illness, like schizophrenia, i.e. how do these genes influence brain development and function, looking at how the environment contributes to risk in its influence of brain development and function, then leveraging this information to better identify new targets for the next generation of therapies for schizophrenia and related neuropsychiatric disorders. And so we were actually a relatively new institute founded in 2010 when some people left NIMH to start this institute to put a pretty wide berth of people in a sort of different team and do team science, all surrounding a common goal of better understanding mental illness and neuropsychiatric disorders. And so what I primarily work with is human postmortem brain tissue. And here, led by Joel Kleinman and Tom Hyde, have collected one of the largest and most extensive human postmortem brain repositories in the world. We've collected over 2,000 samples, largely through medical examiners' offices, which are non-hospital deaths in the state of Maryland and now a few other sites. We've also done some work trying to generate cell lines from these subjects. And our rate of donation is now actually over 500 samples a year across 4 medical examiner sites in 4 states. And so all these brains are collected under a very rigorous IRB, and we take detailed information on the next of kin to try to put together these clinical histories. And we also, which is important in today's talk, do full toxicology on many different compounds, either in blood or brain of the deceased. And one of the tools that we've been primarily using has been RNA sequencing of human postmortem brain tissue. So we'll take a block of tissue that we've obtained, dissect out a specific brain region, and extract the messenger RNA. And so what we do is we then sequence it with these new technologies to identify the levels of different molecules in brain tissue and ask if those levels differ between different exposures or different diagnostic groups. And this was actually part of a larger project related to schizophrenia that was also recently published this summer in Nature Neuroscience, where we profiled about 500 subjects and did extensive RNA sequencing. And here the larger project involved looking for how different genes were regulated differently across brain development. So we actually have a subset of subjects that are second trimester prenatal samples all the way to age 85. And so a lot of genes changed in their expression across development. We can also ask how different genes associate with illness and how local genetic variation influences the levels of these genes. But sort of in doing this project, this other interesting project came out of it, which is looking at the effect of smoking on a human brain across development. And we are particularly interested in this because there's been some epidemiological evidence linking maternal smoking during pregnancy to subsequent development of schizophrenia later in life in the offspring. And this has been one of the more convincing studies of this sort of maternal smoking during pregnancy on mental illness risk, prospectively from these large epidemiological cohorts in Europe. There's also been some smaller, mixed, or maybe lesser evidence for smoking during pregnancy affecting risk for other disorders that are also neuropsychiatric or neurodevelopmental, including ADHD, Tourette's, and autism spectrum disorder. However, sort of going through the literature, we found that there's really no studies, hardly at all, of human postmortem brain tissue, which we think is the which would be the tissue source by which risk is manifested from smoking, connecting smoking to development of schizophrenia. And so we then wanted to answer this and see what are the actual genes that are pointed to during either pregnancy or as an adult smoker that get affected by smoking. And so we used a subset of those subjects I just described, 240 subjects that we assessed smoking in, of which 33 were second trimester prenatal samples. There were about 17 smoking unexposed and 16 smoking exposed. And in our non-psychiatric controlled adult samples, there were 150 unexposed and 57 exposed. These samples were mostly African-American in the prenatal and about an even mix of Caucasian and African-American in the adults, and they tended to skew a little bit more male in line with the different, the encashment proportions of the medical examiner's office. Here we used toxicological measurements of nicotine or codeine detectability, and these actually were very highly correlated with next of kin reporting on sort of the smoking of history smoking in the proband. And so the first analysis we did was we looked at the 33 prenatal subjects and asked which genes had different expression levels in the exposed versus unexposed groups. Here we found 14 genes that were significantly different with smoking exposure. I'm showing 6 here. So on the y-axis is the level of expression for how much of that signal is present in each brain sample, which is each dot. And here it's stratified by exposed in blue and unexposed in red. And then the p-value shown there is the degree of significance for that particular effect. And so here we saw, a handful of genes. And so these are actually pointing to specific genes affected by nicotine exposure in the developing brain. And if we actually look at these, if we look in the adult samples, we're actually kind of surprised because there was actually a lesser effect of smoking, perhaps due to the heterogeneity of the effect on these subjects. In the 207 adult samples, we only found 2 genes differentially expressed by smoking status. The strongest one was this gene Marco, which we found significant in our sample, which we replicated in a independent set of schizophrenia patients, and also showed a significant dose response with the degree of smoking in adulthood. However, we then focused more back on the genes that were differentially expressed in prenatal life because those seemed like they were more interesting. Because when we looked at those genes, we actually found very strong enrichment for those being previously implicated in autism spectrum disorder from genetic sequencing studies. And so on the left, we're just stratifying our 14 genes in the prenatal brains that were exposed by whether they were previously associated with autism or not. And so 5 out of the 14 were previously associated, which is strongly enriched compared to chance. And so the other thing that was kind of interesting was that if we looked at those 14 genes as a set in brains of subjects with autism and controls that we acquired from public data on the web from a published paper, those genes in the cortex were actually more highly differentially expressed in adults with autism compared to unaffected controls, suggesting that maybe some exposures in pregnancy might sort of manifest later in life in autism spectrum disorder. There's also a large number of genes, which was, again, a little bit surprising to us, where there was different effects of smoking exposure on the brain, whether you were a prenatal or an adult subject. And so there's basically different effects of gene expression across the lifespan. So 2 such examples are shown in these box plots where there's a large difference in expression by smoking status in the prenatal samples and a lesser effect in the adult samples, even though the expression of this gene changes over time. And so some of these effects might go away that were affected in prenatal life that are no longer really nicotine relevant, at least through the mechanism of direct smoking in adulthood. And what was sort of interesting about these was that there was actually a stronger effect in the prenatal samples than the adult samples. So almost 3 times more genes had a stronger prenatal effect than an adult effect. And lastly, these genes with differential regulation across the lifespan were strongly enriched for sort of expected gene sets or gene pathways like nicotine addiction or other very neuronally focused gene sets and pathways that are related to development and function. Among those genes with different developmental enrichment, with different developmental effects across the lifespan, we also found strong enrichment for preferentially autism spectrum disorder with lesser effects of different neurodevelopmental gene sets. And so these are genes that are basically differentially susceptible to nicotine in prenatal compared to adult life and showed association with autism spectrum disorder genes. So in conclusion, we were able to identify stronger gene expression effects of nicotine exposure on the developing cortex compared to the adult cortex. We were also able to show that nicotine in the developing brain may relate to neurodevelopmental disorders later in life. And this also pretty much directly highlights the biological effects of smoking during pregnancy on the developing brain, where we can see the effect of each gene, on each gene of the effect of smoking. And so this points to particular genes or pathways that might be especially implicated in smoking during pregnancy. And so these might be the biological readouts of such exposures. And so just as future work on this project, we've also completed RNA sequencing of a different brain region, the nucleus accumbens, which is important in addiction, in adult non-psychiatric controls with and without smoking exposure. as part of an NIH grant with RTI, and the PI of that is Dana Hancock. And here at Libre, we're also focusing on some mouse studies of smoking exposure to try to recapitulate the effects that we've identified in humans in different model species, and that's here with Terry Martinovich and a joint PhD student, Brianna Berry. And so with that, I'd like to thank you guys all for your time. This work was, again, led by Steve Semick, who's in med school now, and involved with work with a lot of collaborators, especially Dana Hancock, Tom Hyde, Danny Weinberger, and Joel Kleinman, and funding from NIDA is provided at that accession number. And this is also partially funded by the Libre Institute for Brain Development. And so with that, I guess I can check the chat for questions if that's sort of the format we'll be doing. And again, thank you guys all for your time. It's great to be involved in some outreach based on our sort of relatively basic research.
Thank you so much, Dr. Jaffe. Just a reminder, we will wait to answer questions until the end of the presentation, but please continue to type them into the chat box. I would now like to introduce Glenn Zarnecki from the Southeast region of the Tennessee Department of Health. Glenn is the regional director there. You can find his full bio in the chat box. If it is not there, we will resend that into the chat box. Glenn, you can take it away.
Okay, thank you. Let me see if I can advance the slides here. Okay, let's see. There we go. Very good. Actually, I'm still struggling. If someone could just advance those for me, you can move on.
Yes, Glenn, we can just do that for you. Not a problem.
Great, thank you.
Of course.
You can go ahead and advance past the first one. Okay, great. So thank you, Dr. Jaffe. It's obviously, as an administrator, not with a medical background, I'll be giving you certainly a more simplified approach or an example, rather, of a program that came, kind of fell into our laps in Tennessee and has proven to be very, very beneficial. I was interested to hear his findings related to the additional developmental disorders that we've probably only begun to scratch the surface of in terms of that kind of return of investment. Obviously, you know, we've been concerned about smoking during pregnancy as the leading cause of premature and low birth weights, particularly in Tennessee, where our pregnant women are twice as likely, unfortunately, versus a national average to smoke. Obviously, we know that quitting smoking reduces placental abruptions, stillbirths. It obviously improves the flow and oxygen to the baby, reduce risks of SIDS, orofacial clefts, risks of future and health and behavioral problems that Dr. Jaffe just mentioned. Next slide. So Tennessee is, I was actually attending a NACHO conference, I believe it was back in 2013, and we had just learned in Tennessee that we were going to start to receive some tobacco settlement money. The state of Tennessee had been receiving it for some time, but we had not really seen any in our department. So with this knowledge and my ability to attend a conference in NACHO in Dallas, I believe, like I said, 2013, 14, we learned about the Baby and Me program. The program was started by Lori Adams. By the time we really got involved, we were one of 15 states. We've now been in it since May of 2014. There may be other states involved probably at this point as well, but we started the Baby and Me program in the 10 rural counties that are my region surrounding Chattanooga, Tennessee, in the southeast portion of Tennessee. And very, very quickly, as each of the counties across the state, 95 counties in total, were each given access to tobacco settlement dollars, it did not take long for many of those counties to quickly understand and know the potential benefits of this program, and they signed on as well. Next slide. So when we received the Tobacco Master Settlement dollars, the 3 goals that we were given through our department was to reduce pregnancy smoking, reduce children's exposure to secondhand smoke, and to prevent youth initiation. We have several vast programs going on across the state to address these 3 goals, but we really utilize primarily Baby and Me, of course, to try to accomplish our first goal, to reduce pregnancy smoking. Also, and I'll talk about this a little more in the future, we converted our program. That probably the most exciting thing about Baby and Me, besides the return on investment and the improvement in the health and healthy babies being born across the state, is in 2017, and I believe we're the first state and only state at this point to have been successful in this endeavor. We moved our Baby and Me tobacco-free program from being funded by master settlement dollars, rather, to being funded by our Medicaid program in Tennessee, which is known as TennCare. So now the activities that we provide, the services we provide in our health department, are reimbursable. About 85% of our enrollees are Medicaid eligible, TennCare eligible, and so our funding going forward is going to be completely financially viable thanks to our partnership with TennCare. Okay, next slide. We chose Baby and Me. It's an evidence-based program. We make it available to all smoking mothers, regardless of income. Most of the programs that we provide to our health departments are income-based, but Baby and Me is not. We don't care what the mother's income is. If they're smoking, we really want them to quit. We appeal to them at a time in their life when they are most motivated to quit. I think most folks could understand that motivation. Pregnant women enrolled in the program, if they agree to quit smoking, they first attend 4 very short prenatal sessions, which does include a breath test. They are eligible for their first diaper vouchers, and that's basically what the whole program is based on, is providing an incentive for these mothers to quit. We offer them their first diaper vouchers by prenatal session number 3 and 4, which is about the time we ask them to go ahead and establish their quit date, and we certainly want them to quit some point in that time phase. After the baby is born, if they continue to stay tobacco-free, they're eligible for a $25 diaper voucher for every month of the child's first 12 months of life. And of course, we confirm that with a CO breath test that's given in each visit. It's a very, very cheap and expensive machine with disposable straws they blow in, and they get a reading. I think anything above a 6, they continue to still be smoking. A lot of folks will probably ask, well, what about secondhand smoke? We haven't found that that's particularly an issue. It typically doesn't run their CO levels up that high. Within 1 year of the program, we figured out that a lot of the women were being unsuccessful because they had a partner in their home that was still smoking. So by year 2, we added a second set of diaper vouchers. If someone that they are living with, doesn't matter if it's spouse, mother, father, partner, whatever, if they come in and they're smoking, if they too will agree to quit, we will double their diaper vouchers, so they can qualify for up to $50 worth of vouchers per month. And all patients are referred to our 1-800-QUIT now, which is our statewide quit line. Okay, next slide. Dr. Zhang, who is an epidemiologist, a physician with our department, did a study and linked TDH-linked program and birth certificate data from 866 pregnant smokers who were participating in our program. She also looked at over 11,000 pregnant smokers who were not involved with our program. And the 2 groups that she looked at, really, when we looked at demographically, they're very, very similar. You can see from the slides that in terms of less than a high school graduation, the percentages were very, very similar. Household income, less than $50,000 annually. Medicaid, Medicare, again, very similar in terms of those demographics, and pre-pregnancy BMI, again, very similar. Next slide. What we found is that pregnant smokers who attended at least 2 prenatal sessions consumed 63% fewer cigarettes per day during their last trimester compared to non-participants, and probably most significantly reduced their chance of having a low birth weight by nearly 60% versus non-participants. Next slide. So our program has grown exponentially, and the way we look at our potential return on investment is if we compare resident inpatient data with mean length of stay. So in the pink blocks here, you'll see that low birth weight babies, I'm going to use 2016 for example, there were 6,501 low birth weight babies. Their average length of stay was 17.6 days, which came to over $100,000 worth of charges. And we compare that to the 70,272 that were not born low birth weight. Their average stay drops to simply 3.1 days, or an average charge of about $9,700. So right off the bat, you can see a significant amount of savings just by preventing any low birth weight births, and not to mention, and I'll go through some of these other things, some of the sort of unquantifiable developmental differences that Dr. Jaffe mentioned. Okay, next slide. So Dr. Zhang's results showed that out of 309 births to mothers who attended at least 3 prenatal sessions, there were only 15 observed to be low birth weight. About 11.6% of non-participants would have been expected, which was about 4.9% versus 11.6% for non-participant births that would have equated to low birth weights, which reduced that particular group by 21 low birth weights were avoided at that time. And with an estimate of $95,000 saved for every baby born normal weight, we automatically saw just within that particular group an estimated savings of over $2.3 million in hospital charges. Next slide. So we have currently about 8,000 enrollees in our program statewide since the program's inception in 2014 rather. That would equate to about 3,000 babies being born to mothers who attended at least 2 prenatal sessions. We estimate that to be somewhere between 30 and 40% of the women who initially sign up are going to make it to that particular point. And if we're able to apply the formula that Dr. Zhang presented, we would have over 200 births would have been, low birth weights rather, would have been avoided, and well over $5 million in estimated savings. So the return on investment is tremendous, but really much more beyond that. It is the return on investment is really immeasurable. With fewer smoking moms, we have fewer children exposed to second and third hand smoke and some of the maladies that Dr. Jaffe explained earlier, fewer trips to the ER for ear infections, reductions in developmental delays, more frequent trips to the health department where we can offer early periodic screen diagnosis and treatment exams, what we call well-child exams, immunizations, WIC, and so forth. But I did also want to add, I had an opportunity just a few months back. I was in one of our health departments locally in our poorest county, and I was in the conference room, and right next door, one of our nutritionists was presenting this program to a young couple. I could hear that they were very, very enthusiastic about the program, so I did what I don't normally do, and I stepped in there and I asked them if they would mind me talking to them a little bit. That particular mother, they were pregnant with their first child, young couple in their 20s. She had been a 1-pack-a-day smoker. He had actually been a 3-pack-a-day smoker. I talked to them a little bit about, so what is the average cost of a pack of cigarettes these days, that being somewhere between $5 and $6 in Tennessee. So immediately we talked about the fact that the mother had already quit. She was excited to get on the program. The father was down to maybe half a dozen cigarettes a day. So right off the bat, we were talking about an immediate savings for them of probably $25 a day. We talked about that and extrapolated that, of course, over the course of a month. And suddenly you've got $500, $600, $700 worth of savings alone just by them reducing or quitting their smoking altogether. And with our program, then they were going to be able to add at least $50 a month worth of diaper vouchers. Those same vouchers can now be used for baby wipes, which we all know that have had young ones. Those can be very, very expensive. So, you know, anecdotally, it's very exciting to be able to talk to individuals like that to be able to put it down on paper and see the number of low birth weights that we've potentially avoided, and just knowing that we have a program that can help those mothers who are, have the highest desire to finally quit smoking has been very, very impactful for the state of Tennessee. Thank you.
Thank you so much, Glenn. Just a reminder that we will wait to answer questions until the end of all the presentations. However, you can find full bios in the chat box right now. I would now like to introduce Lisa Dixon-Gray and Amber Miller. Lisa is the Women's Health System Coordinator with the Oregon Public Health Division, and Amber is the Nursing Programs Manager with Yamhill County Public Health. You can take it away, Lisa and Amber.
Thank you. Thank you, ASTO Partners. This is Lisa Dixon-Gray, and I'm going to talk a little bit about Oregon's MCH, Maternal and Child Health Title V Block Grants Smoking Priority, and then I'm going to pass the presentation over to my colleague, Amber Miller, so she can talk about what's happening in her county. Title V is one of the largest federal block grant programs operated through HRSA, and it's a key source of support for improving the health and well-being of the nation's mothers, children, including children with special health care needs, adolescents, and their families. And all state maternal and child health programs receive Title V funding. And Title V has a list of priorities that states choose, and smoking cessation is one of those specific priorities with 2 performance measures. The first being the percent of women who smoke during pregnancy, and the second being the percent of children who live in households where someone smokes. Next slide. So in the U.S., there's good news. There's also some bad news. The good news is that according to National Vital Statistics data, the percentage of U.S. women who smoke during pregnancy has been steadily falling since 2009. So that's awesome. But here's the bad news. The bad news is that as that percentage decreases, it gets more difficult to achieve full cessation. Those who have found it easy to quit have already done so. And so those smaller numbers means that the easy work has been done, and now it starts getting harder. Next slide, please. So for this 5-year Title V cycle, across the U.S., there are 29 states plus Washington, D.C. that have chosen smoking as a priority issue. And if you want to know if you're one of those states, I would encourage you to get with your state's Maternal and Child Health Title V program and find that out. In Oregon, we did choose the smoking priority, and we are working closely with our chronic disease section, tobacco program and education, tobacco prevention and education program, TPEP, and we have a state level focus, and the locals have also have a county level focus or a tribal level focus. And so in Oregon, the state level focus has been to improve smoking policies for daycare centers. And we've done that so far by banning smoking on the premises of daycare center. So that means that while smoking was banned inside and within certain number of feet away from windows and doors, it was okay to smoke in the backyard or in a woodshed or in a parking lot. So we've taken care of that. We're also at the state level. We developed a online provider training for around the 5 A's in smoking cessation for providers and OBGYNs and family practice providers, so they can make sure their skills are up to speed. We are still looking at following Minnesota's lead, and we're going to be attempting to require signage in daycare homes that would notify parents about third-hand smoke. At the local level, counties have several strategies that they can choose from. Next slide, Amber. Thanks. So we have 4 strategies, and the first 2 are we wanted to really start with adolescents, and so to develop a policy agenda that decreases youth exposure to tobacco products and decreases the likelihood for initiation and use. And that's actually a great strategy to work with our chronic disease tobacco prevention partners. The second strategy is more clinical. It's to use the 5 A's intervention or another evidence-informed program including quitline referrals within MCH programs. And in Oregon, we have several, including home visiting and family planning and WIC, as well as some Oregon-specific programs. Next slide. The third strategy is to collaborate with the ACA's accountable care organizations, and within Medicaid, we have something called community care organizations, CCOs, and dental care organizations. And so we are encouraging our locals to collaborate and to build screening and intervention processes into their work practices. And finally, we have really great insurance coverage through our Medicaid program for cessation. And so we would ask that our counties promote health insurance coverage benefits for pregnant and postpartum women so that people know what they can use their Medicaid insurance coverage for. Next slide, please. So in Yamhill County, a little bit about Yamhill before I pass it on to Amber. They're geographically a small county, but a mighty county in Northwest Oregon, and they have chosen to use the 5 A's intervention and quitline referral for their smoking strategy. And at this point, I'd like to turn over our part of the presentation to Amber Miller, who is the nursing program manager who administers their local Title V program. Amber?
Thank you, Lisa. My name is Amber Miller. I'm the nursing programs manager at Yamhill County, and I'm just going to share a little bit today with you about the intervention that we did or are doing. It's called Healthy Futures, Tobacco-Free Pregnancy and Beyond. And what we tried to do is sort of build upon evidence-based work that's already happening that we know of in terms of incentive-based programming. So as we know, there's risk associated with smoking. I won't review all of those. I think Dr. Jaffe did a fabulous job kind of giving us an overview of how it affects brain development. And so these are sort of the risks that happen as a result of smoking and how it affects brain development. This is our Oregon, Yamhill County data. So we have about 11% of pregnant mamas who smoke, which is about 135 births in Yamhill County. And with those preterm births, we're looking about $4 million to put those babies in the NICU and things like that. So as I said, we sort of built off of what other evidence-based programming does for incentive-based smoking cessation programs. So our intervention has 4 main components: motivational interviewing, increasing incentives, we did a urinalysis, and we did maternity case management. So the goals for us were to increase the pregnant women who quit tobacco and stay abstinent following birth, increase the amount of tobacco cessation resources used by pregnant women in Yamhill County, decrease medical costs associated with tobacco use in pregnancy, and also very important to us in our community was to increase collaboration within our community partners. The tobacco-free pregnancy and beyond, you know, like I said, was based off of other evidence-based models, and so we anticipate that the cost savings will outweigh the cost of the program. It'll reduce the number of low birth weight babies. It'll lower the prenatal deaths. It'll reduce the number of newborn NICU visits and the lengths of stay in hospital. So I'll just talk a little overview of our program staff. So we have a maternity case manager. So this person is one of our nurse home visitors. She coordinated provider referrals into the intervention, worked with prenatal practices to get them to participate in the intervention with us. Additionally, she conducted 5A's motivational interviewing with the participants. She provided training to community partners, in this case, primarily OB/GYN clinics who partnered with us. She analyzed the urinalysis data to determine if they were eligible for incentives, referred patients to other needed services through her case management. She used motivational interviewing to help them increase prenatal care utilization, and she was also the one who provided the incentives. Our program coordinator was part of our public health prevention team. They were tracking and evaluating the data. They were acting as a resource to project staff. Our TPEP coordinator, who's the Tobacco Prevention Education coordinator, provided a lot of technical assistance as part of our team. And then we partnered with our prenatal clinics. We utilized 2 specifically, and they had behaviorists in their clinic who were providing the bulk of the cessation intervention for us in partnership with us. And they were the ones who were giving the referrals into the maternal child health home visiting program. They conducted the lab tests for us. And then our community care organization, we partnered with them to gain funding for the project. They also, we worked with them to put the maternal medical home model in place in those OBG clinics, which as part of that required the behaviorist. So it was sort of all putting all the pieces together. And then, you know, they helped fund sort of the work of the behaviorist. And this is just our map for our intervention. So what we did differently than some agencies is we actually used urinalysis. We had the CCO, we worked with them to cover the cost, and we thought that it would help us reduce the number of moms who might not be eligible because they were exposed to secondhand smoke. But what we found is that it was more costly, and for patients, it wasn't the instantaneous gratification, so the intervention didn't feel as real time for them. We had increasing incentives, so in total they could get about $200 worth of Visa gift cards at each testing period when they were, if they were being tobacco free. This is our first year doing this intervention, and so one of the things that we experienced was not getting enough referrals to really get some good data. And part of that, because we were relying on the behaviorist in the clinic, the OB clinics were having difficulty keeping behaviorists employed. And so just making sure that there was continuity of the program. And then also we do paper charting in our clinic currently for our home visiting. And so just one of the things that we found challenging is just the way that we were collecting data made it hard for us to interpret the data. And then again, the challenges with using urinalysis versus CO2 monitoring. And these are the resources that we give to community members. And I'll turn it back over to ASTHO.
Thank you so much, Lisa and Amber, and thank you to all our speakers. Those were really insightful presentations today. We would now like to give our speakers a chance to answer some of your questions. So if you've not done so already, you can type your questions into the chat box. We have a few that have already come in, so we will start by asking some of those questions. The first one is for Dr. Jaffe. It's a two-part. Is it truly nicotine exposure or smoking? Would you expect to find this among women who use e-cigarettes or NRT? Or is it more likely that the non-nicotine components of tobacco smoke, the toxins and the reduced oxygen, cause the development changes?
Thanks. That's a really good question, and something we kind of struggle with in interpreting some of our results. I do think that our data mostly more points to the nicotine exposure, just because the genes that were associated most with nicotine exposure in the prenatal or differently across the lifespan pointed to genes that were associated with like the functions of the nicotinic receptors, which is sort of this predefined gene set that was like among the top enriched. That being said, there probably are effects of the toxicants on the developing brain. There's just not that much known about the enumeration of them across brand and across all sorts of other aspects of smoking that makes it hard to, find commonalities across those analyses. So I think that we are finding more likely nicotine effects, but again, it is hard to rule out the effect of smoking versus nicotine directly. So therefore, I guess you might expect to see more similar effects with e-cigarettes, but that's something that we'd have to do a study and really evaluate that. A lot of these samples were collected before e-cigarettes were really a thing, so everybody basically smoked cigarettes.
Great, thank you so much, Dr. Jaffe. The next question we have is for Glenn. What percentage of pregnant smokers who enter care agree to attend the BMTF prenatal cessation sessions?
We find that a vast majority of pregnant mothers that we at least, introduce the program to are going to, at their initial visit, agree to sign up. So I'm guessing that's, and we don't measure that unfortunately, but I'm guessing that's somewhere between 80 and 90%. What we do measure is of course their longevity with the program, and about 35% of those are going to get to the point of having attended at least 2 prenatal sessions. And it's important to note that, it is that population that actually saw that reduction in low birth weight. So we recognize, first of all, that quitting smoking is extremely difficult. We also recognize that, those who don't necessarily come back for all the prenatal sessions or after the baby's born, all 12 months to get all the vouchers, we still recognize that those women are very likely at least reducing the amount of smoking, or at least quitting for a certain time period. Potentially, more than likely picking it back up maybe once baby's born, but we've still seen that reduction in low birth weight. So good question, and there's still benefits even for those who we don't end up recording as being sort of full participants in the program.
Great, thank you so much, Glenn. We have one more question for you. How did you get the Baby and Me program Medicaid reimbursable? The state is looking to fund it at the Minnesota Department of Health.
Well, gosh, we had a few tricks up our sleeve on that one. No, honestly, the relationship that our department has with TennCare, our Medicaid waiver folks in Tennessee, is just very, very, very close one. There's a number of programs that we have been providing that have been TennCare reimbursable in our health departments for many, many years. Those being specifically the EPSDTs for TennCare recipients. We have a couple of home visiting programs that we call Help Us Grow Successfully, or HUGS, our CSS program, which is Children's Special Services. We've had a number of programs that TennCare has reimbursed for over the years. We've also, and probably even more to our ability to make this happen, is the fact that there's just been a lot of Department of Health employees who have ended up employed by TennCare, and so just that close personal relationship. But we had, like I said, started the program with the tobacco settlement dollars, but it wasn't long before folks at TennCare began to be aware. And like I said, about 85% of our Baby and Me participants are on TennCare already. TennCare is obviously responsible for offering cessation programs, and so it was just a perfect marriage. We arranged a few meetings. It took us well over a year for it to get fully implemented. But from the very, very beginning, the medical leaders within TennCare were nodding their heads around the table as we were presenting our results. And so it really, even though it took a long time, it was a fairly easy process because everyone was kind of on the same sheet of paper.
Thank you for that response, Glenn. We had a question come in for both Amber and Lisa. You can both answer one first on the other, or just one of you. You may have already spoken to this, but there's a question around replication of the program. Any suggestions or barriers?
This is Amber. I guess to clarify, we tried to model our program off of a program here in Lane County called Q-TIP, which is quitting tobacco in pregnancy. So we sort of met with them to kind of get what worked for them and what didn't work for them. I think for us, what worked well was the collaboration with our community partners. I think that was really huge, getting buy-in from our CCO and our prenatal practices because, they find the work important as well. And so having a champion who was willing to kind of be in the homes and help these mamas get the services they need after they leave the OB clinics was pretty big. And again, I think for us, the other sort of biggest learning part was just how we collect and utilize data. So we just did a PDSA cycle on this first year intervention. And so we've made some changes to how we will be implementing going forward. So our prenatal practices have agreed to sort of do more of the data collection and more of the interventions in office. And then we'll sort of help support that work by doing the home visiting and the 5As out in the homes with the moms.
Great, thank you so much. And this question is for Glenn again. Does BMTF address postpartum relapse?
Well, we normally kind of operate under a one-strike process. So if mom has been smoke-free and kind of has a relapse, like you say, we'll try to turn around and do a follow-up visit with her about 2 weeks after that initial sort of slip up. Obviously, if the mother's come back to us and is committed to staying quit, but it's kind of a one-strike program. Unfortunately, we don't have anything for those who relapse fully. Now, obviously, if they become pregnant again, they would be eligible for our program. What's also unfortunate, we've actually had mothers that have become very, very successful in quitting and have then gotten pregnant again and came back and wanted to benefit from the program. And we said, well, unfortunately, you're now a non-smoker, so we don't have a program for you. But, positive turn of events.
Thank you so much, Glenn. That is our last question for the day, but we would like to thank everyone who joined today's webinar, especially our presenters and partners. We invite you to visit our website, astho.org, to access a suite of materials ASTHO has developed that are intended to help state and territorial health leaders consider policies and practices that promote healthy early brain development. We also ask that you fill out our evaluation. We have posted the link into the chat box, and it's very important to us, so please take the short amount of time to fill that out. And as always, please reach out to the ASTHO team with any questions. We will be following up shortly with a few materials, and we'll let you know when the slides have been posted to our website. So thank you again, everyone, for joining us, and have a great rest of your afternoon.
Thank you.
Thank you.
Thank you.